For some women, it's like, okay, it takes 2 seconds and it hurts for 2 minutes. I'll do a uterine biopsy. Then I have like a whole like year I can work with them. And if they have a little bleeding, I know what it is. It's just hormonal imbalances while we're getting everything together. But a lot of doctors can't do that. So that's a problem there if they have no one that can actually manage their bleeding issues. That's why most doctors are giving these tiny doses. You're not going to bleed if you give no hormones to grow anything.
Well, it's a real pleasure to have Dr. Felice Gersh on the show again. My favorite. Welcome.
Well, thank you. I love coming back.
You are one of our most popular guests, and there's so many requests and so many questions and so many comments and all the YouTube podcasts that I've given. And I'm like, okay, our women want to hear more from you. And I'm super excited that you're coming into our membership group to talk really one-on-one just for a live Q&A with our group. So I'm appreciating that. And any questions women have later on, we're going to keep going back to you. And I'll have links to the show notes and how to reach out to you, of course, as well. So in our last episode, in our first episode, we covered hormone therapy basics. I'll have links to that in the show notes because we're going to kind of bypass that. We've done it. We covered mammograms. We covered the super physiological dosing for optimal aging. And that last episode did so well, and women wanted to learn more. They wanted more details. And in that episode, you covered a lot. And I encourage women to please go back to that so we don't have to repeat too much. But we talked about cycling progesterone in and out every 14 days. You covered that we need to search for a bleed to know where we are in the optimal range while in the perimenopause phase. But some women wanted to really learn more about the rhythmic dosing. And you explained it's possible, but a little complicated. And most women don't even want to fuss with that. But evidently we have a group of women who are listening who are ready for this and are just eating up and waiting for these details. So just to explain a little bit that rhythmic dosing is different than cycling. The rhythmic is increasing and decreasing the dosage like within a month, whereas the cycling is kind of taking it in and out during the month. And I understand that every patient is different, and this isn't precision medicine, and you called it ballpark medicine. But generally, why don't you give us an example of one of your patients or any information you can give a woman and how you would rhythmically dose her HRT?
Well, rhythmic is also sometimes called physiologic. So basically, for people who don't know what we've been talking about, it's trying to really mimic the menstrual cycle, which is a very complex entity in terms of how the hormones are coming and going. And it's not like you have what we call static dosing. That's what is most commonly being utilized today by doctors who utilize hormones at all, is extremely non-physiologic. In other words, it doesn't in any way match up with nature, not even close. They give a tiny dose of estradiol, sometimes not even estradiol. They give something else that's biased, which is another topic, a blend of estriol and estradiol. But they give a static dose, and it's usually very small, very tiny dose, and every night a dose of progesterone, typically orally, a pill. And it's definitely not related to a menstrual cycle at all. There's no female anywhere on the planet that ever has hormones coming out of her ovaries like that. So the idea with rhythmic or physiologic is to try to replicate the beautiful rhythm of the hormones produced by the ovaries. Now, that is complex. And most doctors don't even want to touch it because it will always, if you have a uterus, of course, give a period, because that's what a normal cycle would always result in. And it's going to give you a different level of hormones throughout the cycle on different days. So it's totally the logical thing to do. It's why would we not want to replicate nature? I always say the biggest failed experiment in thinking that we're better and smarter than nature has been ultra-processed food. I mean, like, we can do better than nature. We'll make food that never spoils. We'll make food that sits in plastic for who knows how many years. And that has not really worked out well, as everyone knows, based on the chronic disease states and the epidemic of obesity and diabetes. So we definitely don't want to fail again by thinking that we can outsmart nature. I always think nature is smarter. Now, we lose our hormones because we lose our fertility. And that's okay that we lose our fertility, because if we stayed capable of becoming pregnant throughout our lives, can you imagine the mortality rate of women in their 50s and 60s getting pregnant? They would die, and especially thousands of years ago. So, but unfortunately, the way it works is that the hormones are tied to fertility. So we all will lose fertility. We all will lose our hormones. So when we're healthiest is when we have menstrual cycles, when they're rhythmic and we have the hormones coming and going. And there's a lot that happens in terms of how genes are expressed, tumor suppressor genes, and how the receptors are interacting when you have these beautiful rhythms of hormones. So once you get to the acceptance that and belief system that hormones are really good and that replicating nature is logical and the best way to try to restore or maintain an optimized state of health for the duration of our lives as best we can. So then why can't we do it? Well, number one, we sort of can, but we sort of can't. The problem is science and research has not backed us up in terms of providing us clinical data. There are really no good studies at all, no clinical studies helping us to replicate the menstrual cycle by how do we best dose it. So back 20 plus years ago, a woman named Susie Wiley came up with her own version by a lot of trial and error. And it was brilliant, really. It was so ahead of the curve to come up with this idea of replicating the menstrual cycle. But probably it needs to be better. I mean, some of the doses that they came up with, when we do our current, and the assays for measuring estradiol have changed too over the last 20 years. So when we now measure the estradiol levels using the original dosing formulations that were derived from her personalized research back in the day, 20 plus years ago, some of those levels are really, really very high, okay? And the problem is that the progesterone given through the skin, the absorption is variable and not totally predictable. Not that it is with estrogen either through the skin. I mean, this is where the totally personalization comes in, because skin is a barrier. It's really important to know that skin is a barrier. It was never designed. No, nature never figured or anticipated we would try to put hormones through our skin. So everyone has different thickness, different vascular, different temperature, different amounts of fat and everything else that can contribute to how we do or don't absorb hormones through our skin. So it's very variable. And we have no data on what is the best way to give progesterone as a topical through the skin. Even with the estradiol, we don't have any data, like where should we put it? Okay, where should we put it? What part of the skin? And what's the concentration? Like how many milligrams per amount of carrier cream should we put in? So how do we concentrate it? Where do we put it? How do we dose it? So these are the things that we don't yet have really worked out. But even in spite of that, there are some women who really want to try it. And they say, I'm a bold adventurer. I will biohack myself. I understand that we don't have published clear clinical data. It's not illegal. Nobody's breaking any laws to do this, but I want to try it, okay? So in terms of, well, what are you going to do? How are you going to try it? You can start with the basic premises that were derived back over 20 years ago when Susie Wiley was doing her personalized research, and then try to see how your body responds. It can take months, even like well over a year, to try to work with one person to try to come up with the regimen that will actually seemingly work. And it's so important for people to know that we have no published clinical studies on this. I mean, because this is not what we usually want to do. We usually like to have more data, but we have the data of what a menstrual cycle is. We do know that. We know the levels that are and it's a range of, you can have fertile women. You can have fertile women who have quite a different level at each stage of a menstrual cycle. So we do have a lot of menstrual cycle data, but we don't have clinical data on how best to replicate that in postmenopausal women. So these are some of the foundational challenges that we're facing.
Yes, it's like the Wild West right now. I always tell women when they come to me so confused. I heard this doctor said this and the other doctor said that. And I'm sharing myself on the podcast, different doctors with different regimes and different methods. And so a woman will go to her doctor and she'll get told something else. So in the end, I still think, because like you said, we don't have enough clinical data in terms of, well, what works great for most women in that sense. We want to take things in our control. And this is mostly, I wouldn't say maybe all the women, but I would say mostly women who are listening to my podcast. It's called Biohacking Menopause. We're ready for the end of one experiment. We're ready to try different things. There are risks to everything. I personally believe whether you do things or you don't things, that's life. Life doesn't come without risk. And evidently the women in this audience, they're ready to play around, I would say, and to take that risk. I always encourage women to say, if you are going to play around, please just tell your doctor too, like inform the doctor. I don't know what your background is. I don't know your health history. So it's good to inform. And maybe if you're lucky, a doctor will be working together with you and say, yeah, let's try this experiment. Let's see what happens. You're ready to do it. Let's go for it. So that's what, where they're listening to you, they said, yeah, I would like to see this rhythmic dosing. And even some of the women in my community now, including me, we're playing around with progesterone and 100 milligrams the first few days, and then we'll go up to 200. Someone will go 300, and then we go back down to 2 and then 1. And again, seeing how we feel. If we get better sleep, we have better results. And then, of course, testing, measuring, and assessing is our motto here within the biohacking community. So what would then a rhythmic dosing, like if you can give actually, how about you? What do you do personally with your hormone therapy? I'm assuming you're on hormone therapy, but because you know how to do this. I'm not saying every woman should do just like you, but out of curiosity, I was going to ask you what you do with your patients, but why not you? How do you rhythmically or use your hormones?
Well, I'm always trying a little bit of different things. And I'll tell you that I'm at a crossroads of reevaluating a lot of the progesterone issues as well. But in terms of myself, in terms of where I do use I have used every product on the market, just so you know. So, and
I can imagine.
I'm not like intrinsically at all against the commercial products. It's important to know that the commercial products are bioidentical when they say estradiol. And there were other ones on the market that have left the market because of lack of, I guess, a market share. And in terms of what's out there, we have patches, and patches are sort of the mainstay of the bioidentical hormone estradiol delivery system because they're the most commonly used. They're commonly covered by insurance, and money does matter. For a lot of people, it really gets so pricey when they use the compounded products. So I try to make sure that I can help people live within their budgets. So that the estradiol patches are definitely something that people can use. I have certainly used them in the past on myself. Some of the problems that I'm seeing with the estradiol patches, they're pretty much all generic now. You can get Minivel sometimes, but it's very difficult to get a branded product. So the vast majority are generic. Some of them have names, but they're generic names. What happens with these generics, but it can happen with the branded too, but it's even more with the generics, is that the amount of estradiol they deliver, the patches are supposed to last for 3.5 days, kind of a weird number, 3.5 days to be twice a week. And the amount of estradiol they deliver into the woman's bloodstream is more on day 1, less day 2, less day 3, and less even so on the last half day before it's replaced. So for some women, they have to actually replace them more frequently, which insurance companies don't really care for. So I do have a backup system I can share. It's called the Hormone Club, where you can, and also GoodRx, where you can sometimes get discounts if you have to purchase them outside of the insurance plan. Because for some people, there's 3.5 days, it doesn't last. The patches that are supposed to be for 7 days, they never last for 7 days. So I never ever use those. And the other problem with the patches is that for many women, they don't deliver enough estradiol because they were all designed and produced during the time when the mantra was the lowest dose, not the most efficacious, the healthiest, it was the lowest. So even the highest dose patch for many women is not going to deliver enough estradiol, depending on how they absorb it. So the problems with the patches can be that they don't really deliver enough estradiol for the full length of stay that they're supposed to be on the body. And they also may not deliver enough. With the gels, there are 2 gels out there, and they also don't go up very high in dose. So for some women, they even using the highest amount, it doesn't deliver enough. But sometimes it does, but sometimes it doesn't. Some people complain they're kind of sticky. You can't put them on your face. They're alcohol-based. So there are some limitations, and they also go in areas where people sometimes worry about what's called transference, that a pet or another human may touch them where they put the gel, and then some of the estradiol goes to that other person or pet. So that can sometimes be another concern, which doesn't happen with a patch. So I've tried all of these things, so that there's nothing like trying things so that you can discuss it best with your patients, the pros and cons. But those are the things that are most covered by insurance. And for some people, we really have to work with that. And then we can also get discounts through GoodRx and through the Hormone Club. Currently, I am using, and have been for quite a while, the compounded creams, but I've mixed it up with the progesterone, which I'll share in a minute. In terms of the estradiol, so I'm sort of, like you said, biohacking myself. When I used the dosing regimen that originally were recommended through the Rhythmic, like with the Wiley, the dosing, for me, they gave much too high of a dose. I had periods like there was no tomorrow. It was like a little bit like a bloodbath. But it's individual. I obviously am a better absorber. I don't know if that's good or bad. Maybe my skin is thinner. I don't know what we don't know what that means, because really, I can give the same estradiol cream dose to 10 women. They get totally 10 different levels into their bloodstream. That's the talk about personalization. So I think I am a very high absorber. Other people, I keep pouring it in. It's like it just doesn't, it's so hard to get in. It's like, well, let's try to put it here. Well, let's try to put it here. Let's concentrate it differently to try to get it through their skin. They have a real barrier. Mine apparently is more like a sieve. I get it in. It's like, whoa, look at these levels I'm getting. So I had to really tone it down. But this is the kind of thing where we talk about every woman is going to be her own N of one. So because how she absorbs when we use whatever product it is, whether it's the patches, the gels, the creams, and then there's a vaginal ring, which only comes in 2 doses, and that's hard to get. It's never really become very popular. But just so you know, there is also a vaginal ring, but there's not a lot of flexibility with that because it just comes in 2 doses. One definitely too low, and the other one maybe it's okay, maybe it's not. But in terms of like how you dose it, it's really, oh my gosh, you really have to follow. If you have a uterus, what kind of periods are you getting? That's a good marker, and getting levels and so on. It's a lot of labor intense. That's why most doctors are not going to do it, including patients. Most patients don't want to have such labor intense work. But the reality is that if you really want optimal results, you got to put in the effort here, I think, because if you do the default, which is the tiny low dose static, a little tiny bit of estradiol, and then nightly progesterone pills, I can guarantee you are not going to get optimal benefits. You will get some benefits. I don't want to say that it's completely worthless, not at all. You will have some benefits. We know that it can help completely eliminate night sweats and hot flashes. Fortunately or unfortunately, depending on how you look at it, it takes only like a whiff of estradiol or any estrogen product to alleviate night sweats and hot flashes. And even a little bit of estradiol seems to slow bone loss. It won't grow bone and it won't give you optimal bone, but it will slow bone loss. So that's a good thing, even with static dosing. So there are benefits, but you're not going to get optimal benefits for your brain and for your joints and for your cardiovascular system, for your genitourinary system. That's why all those women, they tell them you have to use vaginal estradiol or estriol if they're using that, or DHEA, but you have to use a hormone intravaginally. Because why is that? Because the doses they're giving are so inadequate to the task. So here's like a clue, ladies. If you have to use a supplemental hormone, I don't mean in the beginning, like if you've been in menopause, we want to get a jump start on getting the genitourinary syndrome back in shape. But I'm talking about like for maintenance, okay? If for maintenance, you have to add a vaginal hormone to maintain vaginal pelvic floor, bladder health, then clearly your systemic level is inadequate. That's like a clue, right? Because let's be real. Does a typical healthy 25-year-old woman who's having natural cycles need to take vaginal estrogen? I don't think so. She's like totally fine in that department, right? But if you're 55 and you have to, because the dosing that you're getting systemically is inadequate, then it's inadequate for everything, okay? That's a clue, right? If you can't optimize health of your vaginal tissues and bladder, and you have to use extra, what do you think is happening in your brain and in your bones and in your arteries and in your heart? Like, come on, it's like one body. If it's not enough for one part, it's not enough for the other parts. But when you do a more physiologic dosing and you get the levels up to somewhere, this is like the ballpark, somewhere in the neighborhood of what a healthy 25-year-old woman would have in her menstrual cycles, you do not need extra vaginal estrogen. You don't, because every organ system is getting adequate amounts. That's another good clue. So we have the period as a clue, like does it seem like a normal period, not too little, not too heavy, and how's your genitourinary tract doing? If you're having a lot of bladder infections, you're developing incontinence of any sort, incontinence like stress incontinence, urge incontinence, you have vaginal dryness, you do have painful intercourse, then clearly your hormone levels are not up to the task. They're inadequate. So in terms of what I'm doing, I'm using a little bit of Rhythmic. I'm not doing the full thing, which I did. I did for quite a few years. I did the full on like Wiley type protocol. And it was like too much for me personally, the levels, the doses. And I had so much breast tenderness. I checked the levels, they're too high. So I've dosed it down. And then what I try to do is, and I'm still like biohacking myself, is go up a little bit in the luteal phase. We know that when you make progesterone in a normal menstrual cycle, the estradiol levels are higher than they are in the follicular phase. And that's probably because progesterone downregulates the receptors of the estradiol. So nature puts out a little bit more estradiol to help counter the sort of counter effects of the progesterone, which of course is not being ever going to happen when you're on these tiny doses of estradiol every day with the constant daily, nightly progesterone, because, it's like beating down. The whole point of that is that you don't bleed. It's like you're giving the estrogen and then you're trying to negate its effects by giving the progesterone every night and giving such a tiny amount that it will never create any growth factors, which you need if you want to maintain tissues. That's why I'm so anti that tiny dose static thing. But in terms of a normal menstrual cycle, you have the lowest levels during the period of estradiol, and then it rises some, then you get a big spike that triggers ovulation, then you get an LH spike, and then you ovulate, and then you get a dip, and then it comes up and it goes higher than it did, the estradiol, than in the first half, the follicular phase, in the second half, the luteal phase. So I'm trying to do that by a little bit upping my estradiol in the second half. And then with the progesterone, and then I'm trying to do like one day where I just do a triple dose, but just for one day or a double dose. I'm still working on it.
So you start off with a lower dose. I mean, you're using the creams, the compounded cream.
Yeah,
So you
right.
have, I'm not sure how many milligrams you're taking.
Well, this is going to be so individualized. That's why I don't necessarily want to say, because remember, I can give the same dose to like 10 women and they all have 10 levels. So typically it's a twice a day application. These are not time released. Okay. So if you don't do it twice a day, there's some people that actually just feel better on one. I definitely individualize everything. Most, but not all, would be twice a day dosing. And then,
so then after a few days, you go up. And so whatever that is.
Well, I personally, you asked me what I'm personally doing. So I'm not personally mimicking the whole Wiley rhythmic physiologic, but I'm coming somewhat close. Okay. When you look at a normal menstrual cycle in terms of the hormones, it really is quite a range for normal women who are fertile. So, and I'm just right now, this could change. Right now, I'm doing the same level and then I jump it up and then I do another same level that's a little higher than the first half. So it's like here, then jump up and then here. Okay.
Okay. Like a step up. Yeah. As if
like one step up for the luteal phase. And the progesterone, that I'm still on the fence about. I'll tell you, I have used the topical progesterone, and I can tell you it definitely absorbs. And it's a lot of cream. You have to use a lot because it's not well absorbed. I have quite a few patients on that. I have patients on oral progesterone as well. It's so easy for people to use it. And a lot of people like the sedating effects, but I'll tell you where I'm at with that. The progesterone creams are very good. Now, you do have to use a lot of them, and we have no published data on safety for that it's going to adequately work to protect the endometrium. So people need to know that we have no published data. So we really have to think about people who go into that need to know if you have a lot of questionable bleeding, you have to have ultrasounds, you may have to have uterine biopsies. That's why like a lot of people don't want to deal with that. And many doctors, if they're not a gynecologist, they can't personally deal with that. They can't do a uterine biopsy. That's not in their scope of practice. These are things that I can do for my patients. I know how to interpret the ultrasounds. I know how to do uterine biopsies. So for some women, it's like, okay, it takes 2 seconds and it hurts for 2 minutes. I'll do a uterine biopsy. Then I have like a whole like year I can work with them. And if they have a little bleeding, I know what it is. It's just hormonal imbalances while we're getting everything together. But a lot of doctors can't do that. So that's a problem there if they have no one that can actually manage their bleeding issues. And so that's why it's also, that's why most doctors are giving these tiny doses. You're not going to bleed if you give no hormones to grow anything. So but in terms of the progesterone, this is coming up, I'm going to be trying intravaginal and also intrarectal progesterone. There is data on that. Now, most of the data on progesterone used intravaginally relates to pregnancies to help maintain pregnancy, but we know it's well absorbed. We have data on that. We know that a lot of it does go to the uterine lining where it actually stabilizes. So that is like for women who don't want to have irregular bleeding, who wants that? This may be actually a very good approach. It's just a question of a woman who's going to tolerate that. So I'm going to be trying that out. I'll have to talk to you on the next episode about what my thoughts are on intravaginal. And then when people use it intrarectally, you're not going to have the leaking. That's like the thing, it's not going to leak out when you put it into the rectum because there's a rectal sphincter there. But in the vagina, you put it in, some of it's going to leak out. And people may not like that, because you have to do it for 2 weeks every single cycle, every month, 2 weeks.
So it's like a pessary or some like little pellet if you're sticking in the vagina, or is it a cream that you're rubbing there?
I ordered both. So I spoke to my compounding pharmacy and I got the cream and I got the suppository. So I'm going to be experimenting with all of the above. Talk about I'm biohacking in myself first. But these have been out. It's not like nobody's used these. It's just that I thought that people wouldn't accept them, that people wouldn't like to do this. And I may be right. Yeah. But I'm going to try it and see how I like it or not. because that at least we know, well, not the rectal, but the vaginal, we do know that it's well absorbed. We do have published data. So we're a little bit less out on a limb with that than we are with this through the skin, where we really have to worry about, unfortunately, how much are you absorbing and what's it doing. So we look at periods, we look at bleeding, and so on. So, and then sometimes we have to look at ultrasounds, and sometimes we have to do uterine biopsies. So people need to be willing to accept all of these possibilities. So I'm going to try now. Here's like the trouble with the pill, the progesterone pill, which I have used lots of progesterone pills, including on myself. And a lot of people like the fact that it makes you sleep sort of in a different way, sort of like a deep, almost like a drug sleep. But it kind of is a drug sleep. So here's the thing about progesterone. When you take it orally, it goes through what's called the first pass through the liver. And because you're taking it orally, it goes to the digestive tract. And in the liver, a very significant percentage, and it's not going to be the same for everyone either, but a very significant percentage is converted into a different molecule called allopregnenolone. Allopregnenolone does not bind to progesterone receptors. So what's turned into allopregnenolone is no longer progesterone. It will not bind to progesterone receptors. And that could be a problem, but because we're trying to give progesterone, we're not actually trying to give allopregnenolone. Now, allopregnenolone in the brain activates the GABA receptors. GABA is a neurotransmitter that is sort of like a deactivating. If you think of estradiol in the brain is like activating, it works on the glutamate system. It's activating the brain. It's making you more focused, aware, like cognitively 2 thumbs up, okay? That's estradiol in the brain. Allopregnenolone makes you brain sedated, like brain fog. Now, if you're sleeping, what do you care about brain fog, right? So you're sleeping, it makes you groggy. Now, 5 or more percent, it's just it turns into a hangover the next day. And unless you give very tiny amounts, the women the next day feel like they're drugged, like their brain is sedated. And that's not tolerable. But here's the thing, you're not really getting the same amount of progesterone. We don't know what that's doing in some ways, but I'll tell you some data. We are also giving a lot of allopregnenolone, which is a brain sedative. And it doesn't give you this, it's not necessarily giving you the same sleep phases that you would get if you had natural sleep. It kind of is like a drug sleep, okay? And there are some pharmaceuticals that kind of work through the GABA system, and they're called pharmaceuticals in that we don't say, I don't want to take a sleeping pill. Well, kind of, you're taking a sleeping pill when you're taking this allopregnenolone like this. And there is some concern that maybe this is actually a negative for cognitive function, because you're actually sedating the brain, especially people who are doing this every night. You're sedating the brain with something that gives you brain fog. Now, you do want to have natural GABA. That's very important, but maybe we're overdosing people when we're giving them all of this allopregnenolone through the oral progesterone, and maybe we're actually not setting them up for better brain health with aging by giving them this to them all the time, or certainly even to a higher dose, because when we give it with 2 weeks out of the month, we're giving it at a double dose. 200, and some people it goes up 300 or 400. What is that doing to your cognitive function over the long haul? Now that we have more data on this, I am somewhat concerned. In addition, I found a study that is from 2023, which is very concerning to me. In this study, they gave one estradiol patch, 0.1 milligram. The estradiol level got up to a little over 80. They measured it. And they did what's called flow-mediated vasodilation studies. So they're basically looking at the artery. Is it constricted or relaxed? Where do we want it to be? Relaxed, okay? We don't want our arteries for no reason to be constricted, okay? So what did they find? These were menopausal women. Well, actually, in this group, they created menopause. They gave temporarily. They gave them drugs to get rid of all their hormones. So they were like menopause. Okay, they had no estradiol, no estrogen, no progesterone. Okay, the ovaries were completely shut down. And then what did they do? They gave them the estradiol patch, zero point 0.1, and got levels of a little over 80. And their arteries, they tested for flow-mediated vasodilation. Before they gave the estradiol, their arteries were constricted. This is like when you don't have estradiol, that your arteries are not happy. You're not making nitric oxide. You're not making anti-inflammatory prostacyclins. So their arteries were constricted. They gave the estradiol 0.1 milligram patch. Their arteries dilated. They then added 200 milligrams oral progesterone. They constricted again.
No. Oh, wow.
Yes. Yes.
That's
You
completely
know what?
inflating
My
the whole
heart-
purpose.
Yes, but I only just recently discovered this study. Nobody cares about this study. It's a very small, like, pilot study. It only had like 20 something women. It was a very small study, but this is the results. Like, I'm not discounting this at all. Now, I found this study linked to another study that was done in the 1990s when everyone loved hormones and we were doing a lot of research. And this was another small study. But in this other study, they said they wanted to get what? Physiologic levels of estradiol. The 81, they felt that's inadequate. So they used 2 estradiol 0.1 patches. But realistically, this was an earlier iteration of the patch. So, but they tested the levels too. And they got like just over 140 of their estradiol. Okay? Because they wanted to have physiologic, this, like, talk about advanced. This is in the 1990s, late 1990s. So they gave 2 patches. And these were menopausal women who had no estrogen production. So once again, they used flow-mediated vasodilation, the same measurement. So they measured the flow-mediated vasodilation before they gave any estradiol. The arteries were constricted. Okay, then they gave the estradiol, and they got to over 140, typically the level. The arteries dilated. Then they gave progesterone 300 milligrams intravaginally.
Oh, how interesting. They did this
Isn't
study.
it?
Yeah. And
In
what
the
happened?
1990s, they stayed dilated.
No way. How interesting.
So I think we need to rethink this whole thing. Now, if we gave it, they didn't do any study using it topically, okay? But I would think, but this is obviously my hypothesis, I can't prove it at this moment, but that's what I want to get studies, that it would have the same effect in terms of not creating vasoconstriction and letting the arteries stay dilated through the topical, through the skin application of progesterone, because it's not turning into allopregnanolone. We don't know, is this related to not having enough progesterone, or having the wrong effect of progesterone, or having a negative effect from allopregnanolone? We don't even know. Like, there's no explanation. This is just what happened. Okay, so why would it be that you give the 200 orally? So one possibility that I'm thinking, okay, is that it's the estradiol level. I mean, there's a number of possibilities here. One is that when you have a lower level of estradiol, like you would have like the 81, that would be more like a follicular phase level. You would not have that level in a luteal phase in the second half. By the way, luteal refers to the second half, also known as secretory. That's the second half. Okay. And follicular is the first half. So in the follicular phase, a level of 81 would be not uncommon, but in the luteal phase, that would be uncommon. That's too low. That's not typical. Okay, and it's possible, but it's not typical. It would be somewhere closer to 200, okay, in the luteal phase, but it's not the same level throughout the luteal phase either. It's a dynamic changing thing. But so one possibility is that estradiol creates nitric oxide, it dilates the arteries. Progesterone acts as an anti in some ways. In some ways, they're actually doing the same thing. It's like complex. In some organs, certain things are done identically. They're replicated with the 2 hormones. In other, it's like the yin yang, the positive negative. So it may be progesterone is downregulating because it does act as sort of a estrogen negator in some ways, like sort of like the brakes or the negative to the estrogen, that the progesterone negated the benefit of the low level of estradiol. It was too low. But by giving a higher dose of estradiol, then the progesterone did not, even at the 300, did not counteract the benefits of the estrogen. So it may be that it's, or a combination. All I can say is that I have real concerns now about women having lower levels of estradiol, like in the 80s or something. If we look at this study, and then giving them 200 milligrams of progesterone, and then thinking that I'm doing good. Maybe I'm not doing so much good. Maybe I'm knocking their brain out, like I'm sedating their brain too much, and maybe I'm not helping their vascular system. So it's like, I'm really at a crossroads here. I've just let you know that I really feel conflicted about giving the progesterone 200. However, maybe if you had higher estradiol, but we need data. This is the thing. Because it may be that the progesterone was too high relative to the estradiol for the vascular health, or maybe there's something about the oral progesterone in particular, but there is, no matter what, there's the concern about maybe too much GABA. Like anything, you could have too much of a good thing too, right?
Yeah.
So
I think it's very often like a balance thing. It seems to me we always, at least nature is always going back to nature. It's about balance and not having too high, too low.
I just try to replicate nature. I never think I'm smarter than nature. When is there ever this massive amount of allopregnanolone in a female body? And I don't even know how much progesterone they're getting per se after it gets converted into a lot of allopregnanolone. But if women say they need it for sleep, is that what you're hearing? They want more oral progesterone because it helps them sleep?
For example, that's one of the big ones, but for many reasons in terms of mood or motivation, and they're just feeling, there are women out there I've spoken to, a very high dose progesterone. They're like, that's what saved me. I'm like, wow. I think these are outliers because most women I know.
The important thing for people to know is that if you're giving the mega dosing of progesterone, this is not hormone replacement therapy. This is not. This is using progesterone as a drug. Okay? This is not hormone therapy in the sense that you're replacing like menopausal therapy. This is using progesterone orally as a drug, okay, to get some unique effect for some person. But I would be concerned for those women, like, what are you really doing to your cognitive function long term because of all that allopregnanolone that you're getting? And progesterone is very neuroprotective. It creates myelin sheath. It's anti-inflammatory. I mean, I'm a fan of progesterone. I love every hormone. I want to understand it like, and I hate cliches in some ways, and I love them in other ways. Like, but the expression balanced hormones kind of is true. You want to have the right ratios and rhythms and so on. Not that I don't do like rhythms. I mean, I do rhythms. I don't do ratios because ratios are always shifting. But you want to have something that's rational, I guess is what I'm saying. You don't want something that is so out of the ballpark of what would ever exist in nature. I just want to replicate nature. Nature always knows best. We have never outsmarted nature yet in terms of food or hormones. Now, maybe we've outsmarted them in something, but so far, mostly it's best to try to not mess too much with nature and try to live with nature.
Well, what I'm concerned about is sorry to interrupt, but when you very high dosages of progesterone, then to me, it would shut down the estrogen receptors.
Yes.
I mean,
it will. Yes, it's going to have a negative impact on estradiol. We don't even have data. I mean, there's talk about not published data. There's no published data on megadosing progesterone, except there is, but not progesterone. Because, okay, how do birth control pills work? Okay.
Of course.
Okay.
Yeah.
Birth control pills work because of the progestin. The estrogen, which is typically, most commonly, not exclusively, ethinyl estradiol, the estrogen component that's put in birth control pills has no contraceptive benefit at all. That has nothing to do with the contraceptive benefit. It's strictly to counter some of the androgen effects of some of the progestins that are derived from testosterone, actually. And so given in high doses, they would give too much testosterone-like effect. They would create acne and facial hair. So they give the ethinyl estradiol, they give the estrogen component to increase sex hormone binding globulin to like bind up the extra testosterone level. So it's like it's a funny thing. And also to try to create regular pretend periods. But when you give progestin, and the reason that they created progestins, by the way, is because if you give progesterone, initially they couldn't even make progesterone that you could take orally. It was all digested by the stomach acid. But even when they make progesterone now that you could take orally, most women by far could never tolerate the high doses you're talking about that would be necessary to do what? Suppress ovulation. So the mechanism of birth control pills is through the progestin, the fake progesterones that are given that are actually more powerful. They're actually more powerful as a progesterone than real progesterone, okay? But they don't make any allopregnanolone at all. There's no conversion at all into allopregnanolone. So they have no sedating effect in the brain at all. So they give progestins, these like replacement for progesterone in high doses, and it suppresses ovulation. So it turns off the ovaries completely. And they can't do that with natural bioidentical progesterone orally because almost every woman would feel horrible, really horrible. They would feel like they were walking zombies, okay, because of all that allopregnanolone in their brains. So that's why they use these progestins, okay. So we know that if you give really high doses, obviously if they're menopausal women, their ovaries aren't even working. But yes, I mean, there are effects. It's like a turn off mode. So, and it does downregulate estradiol. So, and we have no published data on giving massive, like supraphysiologic megadoses of progesterone. So I wouldn't really recommend that as a routine thing. Sometimes they've given high doses intravaginally and even orally to try to work on with pregnancies. But that's using it as a drug. Okay, that's not hormone therapy in menopause. That's a whole different thing. And I think it's a very big deal about the effect on estrogen that I'm glad that you brought up, because it is that yin yang thing. And in terms of sleep, I think it's really important that I think a lot of women in menopause who have trouble sleeping, it's because their estradiol levels are too low. Okay, I really think that we are way underdosing estradiol. Like even I have been somewhat underdosing it. But estradiol in the brain is essential for the production of serotonin. There are serotonin neurons in the brain that rely on estradiol for their very function and existence, and they basically kind of like shrivel up if you don't have enough estradiol. Serotonin is what, of course, the drugs SSRIs are trying to increase because they're known to be like they make you feel good, they're calming, they make you feel happier. That's serotonin. Well, what's a derivative of serotonin? Melatonin. So all melatonin is derived from serotonin. Melatonin is essential for many things in the body, many things. It's a potent antioxidant. It works on glucose regulation. It binds to the ovaries to regulate and have a big input on fertility and ovulation, and of course, sleep. Okay, so melatonin is critical for optimal sleep. So if you cannot make serotonin because you don't have enough estradiol in your brain, you will not make melatonin and you will not have good sleep. It's that simple. I think the reason that so many women in menopause are having trouble sleeping is not because they don't have enough allopregnanolone. It's because they don't have enough estradiol and they're not making enough serotonin, and then they're not making enough melatonin, which is another reason that women after menopause who have never had a problem with mood double their incidence of anxiety and depression. And if they've had a previous problem, it quadruples. And it's because of lack of estradiol in the brain, not making enough serotonin. And also it's essential estradiol for dopamine, for acetylcholine, these very vital neurotransmitters, which also Acetylcholine is the neurotransmitter for the vagus nerve. The vagus nerve is very key to having what we call vagal tone, the parasympathetic, they call rest and digest. So you're not going to have proper like rest capabilities if you don't have enough estradiol to make vagal tone. And the nerve signals involving the vagus nerve are both afferent and efferent. They come and go from to the periphery and also to the brain. They're back and forth. So acetylcholine is critical for vagal tone, and that requires adequate estradiol. So I think a lot of our problem is that we are underdosing estradiol. We still are not sure how best to give progesterone, but I'm thinking more and more oral is not the right way, okay? And that it's not that, and then we're trying to treat the deficiency of estradiol, like what you just discussed, by megadosing, some people, megadosing progesterone because of the suppressing effects on the brain that it sort of like takes you out of your misery if you're in a little bit of a stupor. I'm concerned about long-term cognitive function as well by putting so much GABA into the brain in ways that it was never expected or intended. So I think that we have a lot of questions, and I wish that for this interview that I could give more definitive answers. But I always say the first step in solving a problem is to understand it. We have to ask questions. We have to demand research. And that's one of my upcoming missions, is to try to get funding to do even little studies, just some pilot studies, like with 30 women, to just measure some of these things so we can get some basic knowledge, scientific knowledge of what's happening when we give hormones in certain ways, in certain doses, and so on. And we were talking about this, the problem of finding doctors who even care about giving any hormones, let alone something beyond just these tiny static doses that they're giving now. And so to that end, one of my missions for 2025 is to create mentorships for doctors who are interested, because there actually is a growing group of doctors who really are interested and they don't know where to turn. And often they turn to the wrong sources for information, and then they're doing protocols that really make no sense, like biased. And they're trying their best, but it's really, they're not doing the right things. Or they're just giving the tiny doses of static dosing of estradiol and progesterone because they feel they're doing something and something is better than nothing, and that is probably true, but it's certainly far from optimal. So I'm going to create mentorships and create courses that will be available to both medical professionals and the lay public alike, so that they can actually go in with maybe more information when they see their medical practitioner, and also refer their medical practitioners, if they're interested, to maybe take a course or two and learn some fundamentals that they never were taught in medical school. I don't fault the doctors. They were taught nothing. They have studied 80% of medical healthcare professionals today, and that includes doctors, nurse practitioners, PAs, 80% were not practicing in 2002 when the Women's Health Initiative came out and transformed the landscape of hormones and the thinking about hormones in a stupid, really stupid and negative way that we are still not even close to recovered from. And so they were not taught anything about hormones. They were taught nothing about menopause except they're dangerous, they're bad, they do all these bad things. So they were taught nothing. And now suddenly, well, I should give hormones. I have no idea what to do. That's what they're saying to themselves, because no one taught them. They don't know where to go. And then there are people out there who have no credentials, no understanding, and then they're teaching. And it's like, oh my gosh. And that they think that they're learning useful information, and they're not. And so people don't know where to turn. Like, it's a problem across all areas of information now. Like, what's true? What's false? Where do I get my information? Like, who's legit? So, I mean, I'm going to do my best to say, here are my credentials. Here's what I do. Here's my academic affiliations. Here's my education. This is what I've been doing. And I'm never saying I know the best. I'm saying I'm working on it. Everything is a work in progress. And I share what I know, what I don't know, the questions I'm trying to answer. And then we work it through together, because this is a team when you're working with patients, and also when I'm working with other doctors and healthcare professionals, to say, these are the things that we know, these are the things that we don't know, and these are the things that we should rely on and where we're moving. And so that everyone has a foundational understanding of even basics like what is happening in the menstrual cycle. You could ask a lot of doctors, tell me what happens in the menstrual cycle. They would have no clue. If they don't have a clue what happens in the menstrual cycle, they should not be practicing women's healthcare. That's my belief.
Well, sign me up to that research and sign me up to the program. I think we absolutely need this, and not to mention your forget to mention that your clinical experience that counts. I mean, we have whatever research is out there, and you're doing your best to interpret it, but also the credential that you have in terms of working with women and trying different things. It's not the whole world and every single woman, but you have enough to say, look, this is what's been working in my clinical practice and what isn't. And of course, I think the big message here is that we're all an N of one experiment. There's no one size fits all. I love that you are still biohacking your hormone therapy. Like and you've been through everything, and it just shows. And through the training that I've done is that, yeah, we may find a great dosage or perfect delivery method, and then as we age, things change again, and then we have to adjust it. And so I'm speaking to the women in their 60s, 70s. I know there are women out there listening and watching too, because they send me questions as well. Like, I don't know what to do now. It's not working anymore. I'm like, hey, this is this is what we need more research on. So I'm super excited about your program, and I have still a billion and one questions, as I always do. We're going to have another episode, but to kind of wrap things up again, the way we do rhythmic dosing and cyclic dosing, and it's kind of mimicking Mother Nature, and then having a quote unquote fake bleed will give us an indicator if we're in that optimal level. Of course, how you feel is also a good thing. The genitourinary tract, if you're still struggling with urine leakage, if you're still struggling with difficult sex, and all of this is also an indicator that perhaps your estradiol isn't good enough, right? And this is where we need to figure things out. You also mentioned that as we want our hormones as a healthy woman, a healthy younger woman where we were. So those ranges, because I get this question all the time, what's my estradiol should be? What's the number of picograms per ml? And I'm like, there's a huge range. And if what you're saying is saying of a healthy premenopausal woman, then that could be anywhere from their, I don't know, 100 to 600 or correct me if I'm wrong, picograms per ml, depending what part of your cycle. So that range is really high, right?
If you look at those little studies that I described before, it may be for people, and these are things that we're still working on, like for people who are just using, say, patches, okay? It may be that they should do 2 weeks that they're not on the progesterone, one patch, 0.1, and then when they go on the progesterone, do 2 patches. It may be just as simple as that we can actually do better because when you to cover the effects of the progesterone. So I guess we have to say it's going to be next to impossible to find doctors who are willing to biohack with you on this. I'm just being realistic, but I'm going to try my best to get research data so that and recognizing that estrogen is not dangerous. I mean, you would have to be so mega dosing that you would never be doing. I mean, but even with I did the Rhythmic and I was getting super high doses, like nothing actually bad happened. Okay. So the receptors actually start to downregulate if you have too high of an estradiol. But so don't be afraid of estradiol, and try to find a practitioner who's open to maybe a little bit of biohacking and understanding the menstrual cycle. And I'm going to be doing more and more research and I will be sharing. But I think the main takeaway is you want to try to mimic a menstrual cycle to the best of our ability, whether it's just using progesterone for 2 weeks on and then the rest of the month off. Even that is really important. It gives your receptors a chance to reset, and going on don't think like low dose is good. Most women do need like the 0.1 patch if they're on the patch, or they need the highest dose of the gel. So think higher estradiol. Don't think lower, okay? And absolutely, absolutely never accept a level under 50, okay? And you really shouldn't be going over 200, okay? So at least if you keep those guidelines in mind, you shouldn't be going over, except maybe like for the one day when you would be like having the estrogen spike, but leaving that out of the equation, that can go up into like 300s, 400s. But for that's one day. But you definitely do not want to get over 200 routinely, and you don't want to ever get below 50. So at least that gives you some guidelines to take away, right?
I think what some of these women would like. It's just some sort of a guideline. I appreciate that. That's super interesting. We didn't even talk about testosterone or other things, but I do
so much.
I know you already, and I want to always put a caveat in some of these when we talk about hormone therapy episodes, because you obviously, like all the other doctors I've interviewed, are talking about hormone therapy, but in the context of a healthy diet and lifestyle. Like we always have to have that as a base, right? So don't forget
Absolutely.
that.
I always say hormones are foundational, necessary, but not sufficient. If there are plenty of 25-year-old, 30-year-old women now who are obese, who have prediabetes and diabetes, who are metabolically unhealthy, having hormones is not the ticket to perfect health. But if you don't have hormones, you can never optimize your health. You can always do better, okay? And we didn't talk about like breast cancer. We can talk about that another time. But so there's so much you can do that you have total control over, no matter whether you can or can't find a doctor that will work with you. By focusing a lot on lifestyle choices, we talk about the people in the quote blue zones, and that's been controversial now, blue zones, but the typical woman who lives to be 100 and is still cognitively doing well and ambulatory and all of that. But those women, by and large, were not on hormones, and yet and now these are, of course, exceptions to the rule, but those women did not have hormones. And when you look at their lifestyles, that's like the whole blue zone thing. They walked a lot, they ate real food, they had a lot of fiber in their diet, they had love and relationships, they had purpose, so they had sunlight, they slept. So there's a lot you can do, so totally separate from going on hormone therapy, that can make or break you. Honestly, the pillars of lifestyle medicine are essential. They're, like I always say, if health is like 1,000-piece jigsaw puzzle, the 400 center pieces are hormones. But the 600 that are surrounding, and that's the rim where you always start when you do a puzzle, you always start with the straight edges, the rim, the foundation, really to support the hormone foundation. It's like a total thing, like the rim that is the like we'll say the borders and that holds everything together. The rim of the 1,000-piece has to be lifestyle. So it's to see the whole puzzle, you need the hormones and you need the lifestyle. But if all you have is the hormones in the center and you don't have the 600 surrounding pieces of your puzzle, you're not going to know what that puzzle looks like. So you have to work hard. You have to be diligent and dedicated to the cause of healthy aging to actually achieve healthy aging, unless you're that one in millions, like you won the genetic lottery or something. I work in medical probabilities. I can't work that everyone is the outlier, that they can do nothing and live to 100 perfectly. So assume you're not the outlier. So you got to do the hard work with the lifestyle choices, and then do the best you can with the hormones. We're all working as hard as we can to get the best hormones in us, but without the lifestyle, it's not going to get you to your goal.
Well said. we're 10 minutes over time, and I'm so grateful that you're here. I have to let you go, but everyone can find you on your website, integrativemgi.com. You have Facebook and Twitter, Instagram, LinkedIn. I'll have the links to all of these in the show notes. I encourage people to sign up to your newsletter, which is on your website. And you have a free ebook, the Menopause SOS ebook, and the Menopause 50 Things You Need to Know. I'll have a link to that because that was one of the first books I ever read when it was about menopause. And it was just perfect. It was what I needed exactly at that time. So thank you so much, Dr. Gersh, for your time. And I cannot wait to see you again.
Same.